Yep, there it is. Hello.
Going down. It's like a girl like to.
Okay. So today we are going to show ankle and lower leg. We're going to start with the ankle. I'm going to block you probably.
Oh, it's okay. I can.
Heather, do you want me to move out here? You still?
I can do that over here. Yeah. Okay. Starting with the ankle, I'm going to use the 10 by 12 lengthwise. I'm going to have, as far as patient prep, shoe and sock have to come off again. And again, next week when y'all do it, you can leave your sock on if you want to. But on a real patient, shoe and sock will come off. And the pants leg should really come up well above the knee to about mid-thigh. Her pants leg will roll up, so I'm going to do that so that you can all see it better. So think about that. Next week. But if you can't get the pants leg up, just be sure you mention that to your patient. If they really couldn't get their pants leg up, then you would tell them that you would need them to take their pants off and you could put a sheet over them. Okay? And under them if they don't, if they go commando or something.
Awkward.
And then you can just pull the fabric though tight around the leg while you're actually doing your patient's pants leg that come off next week. Okay, so but I could do that on hers, but you just wouldn't be able to see it very well if I pulled this tight, but I could feel for where her knee is to be able to tell. Okay, so starting with the ankle, I'm going to let my patient just extend her leg out. I'm going to center a little differently than what the book tells you. The book says to center between the malleoli. I'm going to show you to center actually a little bit above the malleoli. That way you can culminate off the toes, which I find very distracting on the image because you don't get any information from them, and still get the lower, at least third of the lower leg. Okay? So I'm going to go ahead and kind of center that up before I even get started. I'm going to ask my patient to pull her foot up because I do want dorsiflexion. That's another thing that they tell you in your book. He doesn't say to dorsiflex, but unless you dorsiflex, you're never going to get the space between the tibia and the talus open. So you want dorsiflexion there. Then place my right marker. Now we're hanging in the true anatomic position. So from where I'm standing, I can read this. It will be upside down to your patient when you place the marker. Okay. And can you see where I am? Here's the malleoli are here, and so I'm just above the malleoli. Yes, ma'am.
Do you look for any kind of degrees for the dorsiflexion?
No, just as best they can.
Okay.
Because they are going to be injured, and so you may have limited dorsiflexion, but you should attempt some to try to get that space open.
Okay.
I mean, as close to 90 degrees they can get it, the better, but just keep it straight out, extended, and then dorsiflex up. Okay. Light field, no toes. Light, no toes. Okay. And that's the AP ankle. All right. From the AP, you shouldn't have to do a whole lot here. We're going to do the mortise oblique. And the mortise oblique is just a 15 to 20 degree internal rotation, not a big 45. If you go 45, you start to lose joint spaces being open. Because our goal here is to get the space between the lateral malleolus or the fibula and the talus open. So it only takes about 15 to 20 degrees. Your patient will probably tell you, I can't move my ankle because my ankle hurts. This is not an ankle movement. It's not in the ankle joint. It's really at the hip. The entire leg needs to roll in. And so if you explain that to your patient that the whole leg's going in and they need to turn at the hip. So this should stay straight and then they turn in at the hip just a little bit. You need to just turn in just a little bit. So you're only going to go about 15 to 20 degrees. If I went 45, it would be way and close this back off. That 15 to 20, which is very small, keeping the dorsiflexion, gives us talus and fibula open with that 15 to 20. The dorsiflexion gives us talus and tibia. So I should see the entire ankle mortise open. It should look like a upside down U or an N, pick a letter. But all of that should be open all the way around. Okay, and then I can leave my marker placement the same. My collimation should still be good. There shouldn't be a whole lot of change I have to make with that. And it shouldn't be too bad for your patient because the rotation's coming from the hip. Okay, so that's the oblique. My patient.
In other words, when you rotate internally, you don't have to collimate or anything else. You still don't want the toes and all that.
Correct.
It's the same.
Correct, because you're interested in the ankle joint. You shouldn't have to really make, unless the patient moves a whole lot in that rotation, you really shouldn't have to make much of a change at all from the AP to the oblique. Okay. But just be sure you do get that rotation of the entire leg. Go ahead and relax for a second. Because if she does, can you turn just like your foot in? You know what I'm saying? Where this part comes in, like this. That's not what you want here. You're looking for the whole leg to come in and not just this little part kind of bending in. Does that make sense? Okay. All right. Then we're going to go ahead and do the lateral. So I'm going to ask her to roll up on her right side. Be sure the apron kind of follows your patient and doesn't just fall off. Positioning here, similar to the lateral foot. Okay, but we're going to center for the ankle. I'm still looking for the plantar surface to be perpendicular and the foot to be dorsiflexed. And then I'm going to support the knee. And my centering here is what really changes. Oh, where are you? There we go. I'm going to center to that medial malleolus.
You said center to the medial.
You can put your crosshairs right over that medial malleolus. Okay? And just be sure that the collimation you have is big enough to include all the calcaneus on this one. They do like to see all the calcaneus on the lateral ankle. And you may have, if the person's ankle was very small, collimated a lot. So sometimes you have to open, if you haven't, super tight collimation, then you'll probably have it open enough already. Like her calcaneus is fine on mine. And then I'm going to mark to the anterior surface. And that will be our lateral ankle. Okay. So that's the ankle, those three projections of the ankle. And then we would go into the lower leg. Now, let me tell you a couple things about the lower leg. It doesn't fit on those people, the whole lower leg doesn't fit on the 14x17. If your clinical site is set up to do it diagonally, you can use the cassette diagonally. But they have to be able to tell the CR reader to read diagonally. If it can't do that, then you'll have to go lengthwise. So my suggestion is just go lengthwise. But what happens with lengthwise is you even have a shorter distance that you can include. But because we're showing this with the ankle, we're already up almost halfway up the ankle. So we're going to be good on our overlap. If you were doing just a lower leg, then you would have to make a decision, if you couldn't get all of it, which joint to include, and you would decide that based upon where their injury is. If the injury was closer to the ankle, then you would get all the ankle and as far up the leg as you can get and go back and do the knee. If the injury was closer to the knee, then you would include the knee on the larger film and come back and get the ankle. If it's kind of, you're just doing it and the whole thing hurts and you can't really make the call, or it's right in the middle and it's not going to make any difference, then my suggestion would be include the knee on your larger film, because lower legs are done tabletop and ankles are done tabletop. You can go back and shoot the ankle. If once we get to the knee, knees are generally done in the bucky. So that just saves you from doing an AP and lateral knee that either looks terrible because it was done tabletop, or then you got to go back and recenter and lock everything in to be in the bucky. So, they'll accept a knee that's so-so as part of the tip bib. Okay? So what I'm going to show is to include the knee in as much of the lower leg as we can get. Since she's already in a lateral position, I'm going to leave her in that lateral position and go ahead and do the lateral first, because she's part of the way there. Let her just lift her leg like this, push that out, put the other one in, then take out this and let her roll all the way up on her right side, because now I'm not going to be interested in the ankle, so I don't care if this rolls over and I don't have this perpendicular anymore. I'm going to be more interested in making sure that her knee is lateral. Okay, so this cassette up to be sure I've included the knee, and as long as I have a little bit of light past the base of the patella, then I know I have the entire knee joint, because the knee joint is actually about halfway there. Okay. Now you will have to open up a little bit wider You shouldn't have any light on the table because we're going lengthwise. You're going to have to open up wider for a couple of reasons. We have to get all the patella. You have to include the popliteal area and all the soft tissue of the calf. And some people have very large calves. So, you'll have to open the collimation. That's okay, just open it up to include that. All right, and then we're going to check the positioning based upon the knee. We don't even have the ankle on here, but you can see that I would have overlap because I had this much of the ankle. So I have good overlap. And I'm going to check to see if I have any rotation in the knee. I want to feel the epicondyles on top of each other. I'm going to roll you back just a hair. And I want to feel those on top of each other. So you may have to roll your patient back and forth. If they can't hold it, you can come back with a smaller sponge here to give support to the knee.
And you center that like mid.
Well, it's not going to be quite mid because you're going to include the knee and take everything else you can get. So what you want to do is open up your collimation to the full 17 inches of length you have here. Be sure you have the knee and then just as much of the rest of the leg as you can get. So you're going to be centered more toward the knee. You're really not going to be mid to fit. If you were doing a child or someone who did fit, then you would be mid to fit. And for test questions, yeah, that's where you would center, the middle of the lower leg. But in practicality, that probably wouldn't happen. Okay. But do check this. If you have a hard time getting these lined up, sometimes you can bend the knee a little bit, and that helps. You really don't want the leg fully extended. Notice how she has some flexion here. It will be like when we get ready to do the knee, you have about 20 degrees of flexion. You're not necessarily looking for that 20 degrees here, but a little bit of flexion is better than if she had her leg completely straight down. That's very hard to really position well. So a little bit of flexion will help you feel those epicondyles better. And plus, you can see the popliteal, like I said, and the calf. Then I place my marker toward the anterior surface. And I have a lateral tip fib. And then the only thing left of the tip fib is the AP. So I'm going to ask her to roll back on her back now. We're going to extend her leg out. I'm going to center that up. I'm going to again make sure that my light extends a little bit beyond the base of the patella. I'm just going to center this up. Place my marker to the lateral aspect. Now you do want to be sure when you do this part that you don't clip any of this soft tissue that you have medially. Because depending on the person's knee, they could have a lot of soft tissue that comes medially. Don't clip any soft tissue. You must include all soft tissue.
Or saying we got lots of salt.
Well, and so you just open it up and include it. Now you got 14 by 17. You got plenty of room, so it'll be okay. So I am just double checking here this medial aspect, and I'm looking for equal light field. Maybe a little off based upon the difference between the knee to the calf. Because she was a runner, her calves are larger. Then you would see, then what I would expect, because like her knee is small, but her calf is larger because she's a runner and a walker. And so that can throw your collimation off a little bit, so just be sure you included everything. You can have your patient dorsiflex if you want to. It's not required, but if you have your patient dorsiflex, it does make sure that their leg isn't flopped out to the side in total relaxation so that you have a good AP, and it gives them something to kind of concentrate on to hold their leg still. But it is not a required positioning technique.
It just helps.
It just helps to keep people still.
And so for all these positions, since we're hanging them in a true anatomical position, the markers are where we can aim them.
If you're standing here, yes.
Yes.
It'll be upside down to your patient.
That was my question.
Yes, and I don't know, you probably can't really tell that on the video, but yes. So that will be it. So there's 3 projections of the ankle, 2 projections of the lower leg, and we will shoot an ankle image. We won't do any anatomy though, because there's really not much to the ankle. Lateral, medial, malleolus, talus. It's not very exciting. So we won't do any anatomy, but we will shoot an image. All right. Do I take a space bar again? Bye.